Welcome to the deep dive. Today we're tackling, well, a pretty dense medical guideline all about suspicious skin lesions. It looks very technical, almost like an instruction manual, but hidden inside are these really critical decision points, the ones that help tell the difference between, a minor skin issue and something much more serious.
That's exactly right. And our job today really is to pull out that essential triage knowledge. We want to lay out the structured way professionals figure out what's benign versus what might be malignant. We'll get into the three big ones: melanoma, basal cell carcinoma, squamous cell carcinoma, and importantly, try to understand why we're seeing such a rise in these cases.
And the rise is significant, isn't it? Just to give you some context, our sources point out that back in 2013, skin cancer was actually the single most common cancer type overall in the Netherlands. We're really looking at a wave of diagnoses driven by, increased risk.
Okay.
So let's unpack the scale of this increase first. The source material, it shows that doctor visits for suspicious spots, they went up dramatically. In primary care, it jumped from about 61 per 1,000 patients back in 2000 to 94 per 1,000 just 10 years later. That's a huge increase in people seeking help.
It really is. And it wasn't just more people coming in feeling worried. The chance that one of those visits actually resulted in a cancer diagnosis also went up quite sharply, actually. It went from about 1 in 18 consultations finding cancer to 1 in 10. So the underlying risk, it's undeniably higher.
Right. And we generally know the main cause is UV light, that irreversible DNA damage. But what I found fascinating in the guidelines is this distinction they make about how you get that exposure. It's not always the same, is it?
No, it's definitely not one size fits all. And this is where it gets quite interesting. You basically have two different risk profiles based on exposure type. So chronic exposure, think steady long-term sun, maybe like outdoor workers get day after day. That's mainly linked to the two most common and often slower growing cancers, basal cell carcinoma, or BCC, and squamous cell carcinoma, SCC.
Hey, hang on. So are you saying that those awful blistering sunburns I got as a kid, the really intense but intermittent bursts, were actually a bigger risk factor for melanoma, the really dangerous one, compared to, say, a farmer who's out in the sun constantly but maybe doesn't burn as badly?
That's pretty much what the evidence suggests, yes. Melanoma risk seems more strongly tied to that intermittent, intense kind of exposure, this sort of often marked by severe sunburns or maybe recreational tanning. And the data backs this up. Having frequent sunburns can push your relative risk for melanoma up potentially as high as 2.03 times baseline. It's just maybe a different way the DNA gets damaged compared to that slow, steady wear and tear from chronic exposure that often leads to BCC and SCC. Of course, tanning beds are sort of the exception. They just raise the risk for everything.
Okay, so understanding the kind of sun damage is key. And that risk isn't evenly spread, is it? The sources talk about phenotype risk. Who needs to be most careful?
Well, the highest risk group is generally people with skin type 1. That usually means very fair skin, maybe red or light blonde hair, people who burn really easily and barely tan. Their skin just has less natural defense against UV. But beyond that, your personal history. That's a massive factor.
How massive are we talking? Like, what does having had one skin cancer mean for the future?
It's significant, really significant. If you've already had a BCC or an SCC, you're definitely not one and done. You carry something like a 30 to 40% cumulative risk over the next 5 years of developing another BCC alone. So that history means you need constant monitoring. And connecting this to the broader picture, your immune system plays a huge role too. Patients on immunosuppressant drugs, maybe after an organ transplant, their risk for SCC can shoot up by as much as 100 times compared to someone with a normal immune system. That's a really, really critical flag for doctors.
Wow, okay. So if having had one cancer puts you at such high risk for another, vigilance is key. How do doctors actually move from knowing someone's high-risk profile or their history to looking at a specific spot? What's the assessment process?
Well, they usually start with what's called anamnesis, which is basically just asking targeted questions about the lesion itself. When did you first spot it? Is it growing? How fast? Does it itch or bleed? They combine that information with the patient's background, their sun history, immune status, family history, especially of melanoma or maybe pancreatic tumors.
And then they actually examine the lesion. Is there like a standard checklist they use for describing it?
For general skin lesions, yeah, sometimes they use a system called Provoke. It's just a way to systematically note down the features: its place, radius size, Omtrek shape border, Vlak surface, omgiving surroundings, clear color, and efflorescence, primary lesion type. But when the main goal is that crucial step, telling a harmless mole, a nivus, from a potentially lethal melanoma, They rely on a more specific, well-known tool.
Right, and that's the big question, isn't it? How do you tell the difference between just a mole and a melanoma? What's the specific tool for that?
That would be the classic ABCDE criteria. It's designed specifically for assessing pigmented lesions, looking for signs of irregularity.
Okay, let's quickly run through those letters because this is probably the most useful bit for anyone doing self-checks at home.
Absolutely. So A is for asymmetry. If you drew a line through the middle, would the two halves match, or is it lopsided? B is for border irregularity. Is the edge smooth and well-defined, or is it kind of ragged, notched, or blurred? C is for color non-uniformity. Is it all one shade of brown, or does it have multiple colors? Maybe patches of black, tan, brown, or even non-brown colors like white, red, or sometimes a bluish tint. D is for diameter. Typically, they flag anything 6 millimeters across or larger, about the size of a pencil eraser, though melanomas can be smaller. And E is for evolution. This is really important. Has the lesion changed recently? In size, shape, color, or even elevation? Is it newly symptomatic, like itching or bleeding? And crucially, the more of these ABCDE signs a mole shows, the higher the suspicion for melanoma.
And alongside that checklist, there's the ugly duckling sign, which sounds quite intuitive.
It is, and it's a really useful clinical sign. Imagine someone has, say, 50 moles. Most of them might look fairly similar in pattern and color. They're the flock. If there's one mole that looks distinctly different from all the others, different size, shape, color, that's the ugly duckling. It just doesn't fit the person's general pattern of moles, and that makes it suspicious, even if it doesn't perfectly fit all the ABCDE criteria.
Okay, so let's say a doctor uses these tools and strongly suspects melanoma. The next step isn't just a small biopsy, right? You mentioned it needs a diagnostic excision. Why is it so vital to remove the whole thing straight away?
Ah, yes, this is absolutely critical for getting the right treatment plan from the start. When a pathologist looks at a suspected melanoma, they need the entire lesion to measure its depth accurately. They measure what's called the Breslow depth, basically, how thick the melanoma is in millimeters, from the top layer down into the skin. This measurement is the single most important factor for prognosis and deciding what happens next. It determines the stage, the risk of spread, and how wide the margins need to be for the definitive surgery. If you just take a tiny punch biopsy, you might completely miss the thickest part of the tumor. That means you could underestimate the stage, leading to the wrong treatment plan initially. You need the full picture, the whole lesion, to stage it correctly and give the patient the best chance.
Right, that makes sense. Let's pivot now to the main types of skin cancer themselves, starting with basal cell carcinoma, BCC. You mentioned it's the most common. The lifetime risk is something like 1 in 5 people.
That's the estimate, yes. BCC is incredibly common. The upside, if you can call it that, is that it almost never metastasizes. It very, very rarely spreads to other parts of the body. The rate is tiny, like 0.03%. But, and this is a big but, it's locally destructive. It can keep growing wider and deeper, invading and destroying the surrounding tissue right where it started. That's why treatment is always necessary.
And because of that local damage potential, some BCCs are classed as high risk, even though they don't spread systemically. These need a specialist referral. What features put a BCC in that high-risk category?
Location is a really big one. If a BCC is in what's called the H zone of the face, think of a T shape covering the central face, around the eyes, ears, lips, nose, and those folds running from the nose to the mouth corners, nasolabial folds. That's considered high risk. The reason is thought to be related to how the face forms embryonically. These embryonic cleavage lines might provide pathways for the cancer to grow deeper or spread more unpredictably along tissue planes.
Huh. So the actual structure of the face can make the cancer behave more aggressively in those areas.
Exactly. Other things that make it high risk are size, generally lesions 2 centimeters or bigger, or if it's come back after being treated before recurrent. Also, certain growth patterns seen under the microscope are flagged as aggressive. You might hear terms like micronodular or spreaderig. What's tricky about the spreaderig type, for example, is that the cancer cells grow out in these thin, finger-like strands, almost like roots. That makes it really hard for surgeons to be sure they've got it all, increasing the chance it might come back if the removal margins aren't wide enough.
Okay, let's move to the second most common, squamous cell carcinoma, or SCC. Typically hits older folks, average age around 74, and its incidence apparently doubled between 1980 and 2015.
Yeah, SCC is definitely more of a concern than BCC because it can metastasize or spread. It happens in maybe around 2% of cases, but it's a possibility. The prognosis really depends on the stage, how thick the tumor is, its size, whether it has spread. Like BCC, it's linked strongly to chronic sun exposure. But here's a key difference. Smoking. Smoking significantly bumps up your risk for SCC, which doesn't seem to be the case for BCC.
Interesting. The guidelines also mention something called a keratoacanthoma. It sounds a bit odd. a tumor that can sometimes just shrink and go away on its own.
Right.
But it's treated like an SCC anyway. Why take the aggressive route?
Simply because it can be incredibly difficult, sometimes impossible, to reliably tell the difference between a keratoacanthomoma and a genuine invasive SCC just by looking at it, or even sometimes with a biopsy. Given that SCC carries that risk of metastasis, the standard practice, the safe approach, is to treat them all as if they are SCCs. You just can't take the chance.
Makes sense. Err on the side of caution. Okay, finally, melanoma. We've established it's the most dangerous. We know about the link to intermittent sun exposure, sunburns. What other major risk factors should people be aware of?
Well, beyond sun exposure patterns, genetics and just the sheer number of moles play a big role. If you have a very high number of ordinary moles, say 100 or more, or if you have 5 or more atypical or unusual looking moles, your baseline risk is higher. Then there are specific genetic conditions. The most well-known is probably syndrome, that stands for familial atypical multiple melanoma syndrome. People in these families can have a lifetime melanoma risk as high as 70%. And interestingly, that same syndrome is also linked with a higher risk of developing pancreatic cancer. So all this information leads us to how clinical decisions are made. It really splits things up. The aim is to be efficient and safe. Low-risk problems, things like most actinic keratosis, those precancerous spots, or very low-risk BCCs, or maybe Bowen's disease, those can often be managed effectively in primary care by the GP. But anything that looks like melanoma or is a confirmed high-risk BCC or SCC, that needs immediate referral to a dermatologist or surgeon.
Right. Let's talk about actinic keratosis, AK, that precancerous stage first. It's super common, isn't it?
Yeah.
The stats suggest over a third of the Dutch population over 50 has at least one AK.
Incredibly common, yes. Now, the risk of any single AK spot turning into an invasive SCC is actually quite low, probably less than 1% per year per lesion. But the issue is that people often have lots of them, sometimes dozens, so the overall cumulative risk that one of them will progress becomes significant over time. That's why treatment is generally recommended when someone has multiple lesions. The guideline sort of arbitrarily suggests 5 or more as a trigger, or if they have any lesions that are particularly large, maybe a centimeter or more, or thickened.
Okay, so if treatment for AK is happening in primary care, what are the main choices? The guidelines seem to focus on 5-fluorouracil cream versus cryotherapy. What's the sort of clinical dilemma there?
It's really a trade-off, isn't it, between how well it works and how much hassle or discomfort it causes the patient. 5-fluorouracil cream, or 5-FU, is basically a topical chemotherapy. You apply it daily, usually for about 4 weeks. It's pretty effective, with cure rates around 60%. But the downside is the reaction it causes. It makes the treated skin very red, inflamed, often crusty, and sore. It looks and feels quite raw, which patients understandably don't like. Cryotherapy, which is freezing the spots with liquid nitrogen, is much quicker. Often just 1 or 2 brief sessions in the clinic, but it's generally less effective, maybe cure rates around 40%. And the success with cryotherapy can really depend a lot on who's doing it, their technique, how long they freeze for, how aggressively.
Okay, so that's precancer. What about when it's confirmed low-risk cancer, like a straightforward BCC, or maybe Bowen's disease, which is SCC, just in the top layer of skin? In situ. Excision, cutting it out, seems standard, but you emphasized earlier that pathology before treatment is mandatory. Why biopsy something first if you're pretty sure it's cancer and you're going to cut it out anyway?
Because the type of cancer and sometimes its specific growth pattern dictates the map for removal. You really need that initial biopsy, ideally a punch biopsy, at least 3 millimeters wide to confirm exactly what it is. Is it definitely a BCC? Is it superficial or nodular, or maybe showing some early signs of a more aggressive pattern? That pathology report tells the surgeon precisely how much normal skin they need to take around the cancer, the surgical margin, to ensure it's completely removed. For example, for a standard low-risk nodular BCC, the recommended margin is typically 3 to 4 millimeters of clear skin around the visible tumor.
And why is just cutting it out first, without that prior pathology confirmation, generally discouraged? What's the risk?
Well, you risk getting it wrong in one of 2 ways, really. You might undertreat it. If you take too small a margin because you didn't know it was, say, a micronodular BCC that needs wider clearance, you could leave cancer cells behind and it'll just come back later. Or you could overtreat it. Maybe it was a very superficial BCC that only needed a very narrow margin or even a different treatment like curettage, but you took a standard wider excision resulting in a bigger scar than was necessary. So getting that histology first ensures the treatment is appropriate, not too little, not too much. And when it's done right, based on pathology, the cure rates for excision of low-risk BCC are excellent. Up in the 94 to 98% range.
Okay, so wrapping this up for you listening, the real takeaway from this deep dive seems to be the critical need for a structured approach to risk. Understanding that difference between chronic and intermittent sun damage, knowing how to use those diagnostic tools like the ABCDEs, and really internalizing that for confirmed cancer, pathology comes first. It dictates the treatment map.
Absolutely. And don't forget the basics from the guidelines. Prevention is still key. Limit your sun exposure, especially during peak hours. Use a broad spectrum sunscreen, SPF 30 or higher, when you are exposed. And importantly, consider using an SPF 15-day cream just as part of your daily routine, even on cloudy days. And finally, get into the habit of self-inspection. Check your skin every 3 to 6 months for anything new or changing.
We spent a lot of time talking about sun damage on lighter skin types because statistically, that's where most skin cancer occurs. But let's end with maybe a more provocative thought, something focusing on a risk that's perhaps less intuitive concerning individuals with darker skin tones.
Yes, that's a really crucial point that often gets missed in general awareness messaging. While skin cancer is less common overall in people with darker skin, when it does occur, it often appears in places that aren't typically exposed to the sun. We're talking about areas like the palms of the hands, the soles of the feet, or even underneath fingernails or toenails. These are called acral sites. Sun exposure seems to play a much smaller role, if any, in these particular cancers. And because these lesions don't fit the usual sun damage story and might be harder to spot visually on darker skin, they are unfortunately often missed, both by patients and sometimes by healthcare professionals until they're quite advanced. This frequently leads to a later stage diagnosis and, sadly, a significantly poorer prognosis compared to similar cancers diagnosed earlier in lighter skinned individuals. So it really raises an important question. How can we adapt our public health messages and clinical vigilance to better address skin cancer risk across all skin types, making sure we specifically look for and raise awareness about these non-sun exposed sites?